Hi, my name is Whitney Lamb, and the pathology I chose for my case study is called Achalasia. So for the real life patient I found, I actually discovered her on TikTok by searching rare disease TikTok. She does a video series talking about her discovery of her illness and her journey in getting there. So this is just a short dramatic reenactment of the first stages of her realizing she had her disease. Disclaimer, you can't embed a TikTok into a PowerPoint yet, so I'm going to use a link. So as I said, a little bit of a dramatic reenactment. She goes on to talk about her journey through going to several doctors who just kept telling her that she had acid reflux or GERD and were just prescribing her antacids. Meanwhile, her symptoms were getting worse and worse. And as I explain what achalasia is, you'll start to see why. So what is achalasia? So far, it's not known what it's caused by. It's really a toss-up between an autoimmune disease or a neurodegenerative disease, but there's not really enough research so far to determine a cause. What happens is the nerves of the esophagus become paralyzed, and what that does is really widens the esophagus. So you can see on these scans here, like this esophagus is just very wide, and right here in this x-ray, it's almost the width of the heart here, as you can see. So that paralysis of the muscles is just really causing it to sag, and what it does is when it gets down here to terminate at the stomach, like the lower esophageal sphincter, it stays shut and it literally will not let food through. This is kind of a progressive disease. It'll start off with patients will notice like certain solids won't go down, but it'll get worse and worse and worse and worse as the paralysis really increases, and then soon even liquids won't go down. So some signs and symptoms of achalasia are heartburn from the bile coming back up from the stomach, dysphagia, which is difficulty or pain with swallowing because that sphincter is not opening and closing as it's supposed to, chest pain, which is what you saw Holly experience a little bit, and she goes on to experience again in a video. It's an esophageal spasm, and sometimes it can feel just as bad as a heart attack. She actually ended up going in an ambulance to the hospital because she really thought she was having a heart attack, and then that's what kind of spurred her to seek her more serious diagnosis, because at that point the doctors and her realized like there's no way this could be acid reflux. Pneumonia, weight loss, and vomiting. You saw Holly in the video vomiting. The weight loss is obviously due to the inability to keep the food down and the sustenance down. So that could really start getting dangerous for patients who just aren't getting that diagnosis they need, because at that point they're malnourished. So I've made a couple visual assists to show what achalasia would look like. So first, in this first example, this is meant to show a healthy esophagus, about the width of the spine, definitely not more, and then this is the stomach here, and this is the sphincter. That does not open and close on a diseased esophagus. So here I have my barium mixture, and we'll see how it moves down the esophagus. So you see it filling, and clearly it's passing here through the sphincter into the balloon. It's filling here at the bottom, as you can see. So this is what your esophagus should be doing and what the lower esophageal sphincter should be doing. The stomach is filling. If I had put less in, it wouldn't be coming back up, and that's ideally what would happen. So next we'll move on to the diseased esophagus. You can see that this tube is much wider. That's because of the paralysis in the nerves of the esophagus. I'll pour my barium down. So you can see it filling and filling and filling, but nothing is going down into the balloon. And eventually, as the patient keeps eating and eating and eating, it's just going to come back up. And if they lay down, it's going to come back up. It's very uncomfortable. It's 100% due to the sphincter just not being open at all. So the diagnostic modality of choice, you may have guessed from that example, is going to be a barium swallow by means of fluoroscopy. So this is the modality of choice because it isn't really risky to the patient. It's not very uncomfortable. It can be done very quick, and you can see it live. You can see the widened esophagus on a chest x-ray, but that is not enough to really give a diagnosis and verify that that sphincter is not opening and closing. If a patient is for some reason unable to tolerate the barium swallow, or it's inconclusive, an endoscopy may be used, but it's really not preferred because then the patient has to be put under anesthesia, and it's just a more uncomfortable procedure overall. So treatment can include medications, although that's not really common anymore. These medications, kind of a lot like acid reflux medications, would irritate the esophagus over time, and it just led to a higher risk of esophageal cancer. So a really popular one today is seen in this diagram, and it's the balloon inflation. You can see that a catheter is installed all the way down into this lower esophageal sphincter, and it's dilated, and it literally stretches open those muscles, and it will keep it open. So once it's stretched properly, the balloon will be removed, and the patient often experiences some sort of relief or improvement for multiple years after this procedure is done. Another option is a myotomy, which involves cutting the muscles right here to open that sphincter again semi-permanently. Again, this is one that has to be repeated every so often. Patients can have comfort for up to years. The big stress with both of these last two procedures is just making sure that there were no esophageal tears. So after these procedures, the patient will once again have to do a barium swallow just to verify that there's no leakage in the esophagus. The last choice is a toxin injection. This toxin injection is injected right into the sphincter, and it'll loosen the muscles. There have so far been no adverse effects of long-term use, and patients can experience relief anywhere from 3 months to 2 years. So ultimately, the prognosis of this is there is no cure, but it's still not that bad because all of these treatment options have a very high success rate, up to 90%. They're really not as invasive as they could be. A big worry, though, as I was mentioning before about the esophageal cancer, is because of the sphincter allowing bile back up into the system. These patients are at increased risk for esophageal cancer. So even though their treatment is effective, they should be screened regularly for esophageal cancer. But this concludes my presentation. Thank you.